Any man will likely tell you that guys are the stronger sex. They're usually more muscular thanks to testosterone, but when it comes to longevity, men are actually the weaker sex. We women outlive men. This gender gap hasn't really changed. Women still outlive men. That's not to say that we women have it easy. An actual study in Lancet Public Health found that women endure higher levels of non-fatal heart issues throughout their life. One reason that we have been ignored in clinical research for decades is that we have specific changes in our system every decade of life. And that really contributes to an instability that pharmaceutical companies were not interested in really entertaining. We also have female-specific issues or ailments like endometriosis, polycystic ovarian disease, premenstrual dysphoric syndrome or disorder, and often severe menstrual syndromes that lead into menopausal that are really under-researched. Even in the years I've been doing women's health, there hasn't been much progress. I'm happy to say, though, that that has changed recently, and a lot of women, particularly my women colleagues, are now learning a lot more about how to keep themselves healthy for life, how to transition into perimenopause and menopause. Some of these ailments I talk about are often misdiagnosed and treated incorrectly. But fortunately, the tide, as I mentioned, is turning in the 21st century. There's a much greater understanding and more emphasis on women's health thanks to experts like today's guest, my friend and colleague, Dr. Felice Gersh. Thanks for joining Healthy Longevity, Felice. I'm so happy to see you again.
Well, I'm so happy to be part of your podcast series because these are critically important topics, and I just loved hearing your introduction. All of that is so true. It's so sad how women's health issues have been so sorely neglected, and we're trying so hard to bring them in focus.
I totally agree, and it's exciting that that's happening. I'm thrilled to have colleagues now who are interested in the field and have worked long and hard like you to bring it to the forefront. Felice and I have been traveling in the same circle for a while now. Let me tell our listeners a bit about you. Dr. Gersh is a dual board-certified gynecologist and integrative medicine physician. She's globally recognized as an expert on women's hormones, gut microbiome, and circadian rhythm, and plenty more. That's just the tip of the iceberg. She is the founder and medical director of Integrative Medical Group of Irvine, California, and the author of PCOS SOS, a bestseller book that teaches women how to deal with and heal polycystic ovarian syndrome naturally. Her newest book is called Menopause, 50 Things You Need to Know What to Expect During the 3 Stages of Menopause. I'm really excited to chat with you, Felice. I first want to start by asking you about your journey, and I can love to hear about that in women's health, starting as an OBGYN or obstetrics and gyne, and then pursuing a fellowship in integrative medicine.
Well, sure. I actually am not quite sure why, but from the very beginning of my career when I started my medical practice way back in the 1980s, I intuitively knew that there was more to optimizing health than just pharmaceuticals or surgical procedures. And of course, I incorporated them as well because I didn't shun, I'm not an alternative medicine doctor. I integrate all the different therapeutic modalities and I just try to choose the one that's best suited for each patient. But from the very beginning of my career, I incorporated in my practice a Chinese medicine practitioner, a psychologist, a nutritionist, biofeedback, massage therapist. So I incorporated a whole array of what I called my ancillary therapy modalities. But I myself had no specific training other than in the conventional medical world, having gone through the conventional medical school, residency, and so on. But it was after I stopped doing obstetrics, after 25 years, thousands of deliveries. It was my time to move on into other areas. And at that point, I did something I actually never done before, which was to ask all of the drug reps. At that time, I had so many drug reps coming through my office. And I asked them to show me the original studies that were used to present in front of the FDA to get drug approval. And when I looked at them, I found that many of them had very little difference between the placebo in terms of their efficacy, and yet they had all these additional side effects. And I started to feel a little bit lost now that I wasn't doing the deliveries, and I felt like I was dealing with end stage disease when I did surgeries. I said, can't we be more proactive? Do I have to wait and say, we'll watch it all the time? We'll watch it, and when it gets really bad, I'll cut it out. And so I started thinking I should do more. And I went and I started exploring different avenues, and that's when I ended up actually at a course that was in Portland, Oregon, and one of the speakers there happened to be the director of the Fellowship in Integrative Medicine at the University of Arizona School of Medicine. And I went up to her and I said, you and I are actually here, and we're the only MDs in this room. It happened to be a naturopathic conference. And I said, I'm really lost. I don't know what to do to really optimize my medical approach to my patients. And she said, come to my fellowship. It starts in like 2 weeks, and I know you're qualified. So I went home, filled out the application, and 2 weeks later I was in Tucson, and I did the 2-year fellowship, and I never looked back, only forward. So basically I expanded my therapeutic toolbox in terms of how to treat patients, and it just led me into like a path of exploration. I was a little bit too complacent, I think, for much of my career, accepting what I was told by whoever was the so-called authority. Well, now it's like, no, I really demand really good data. And just because someone's been recommending it or doing it, that won't suffice for me anymore.
Right. Opinion driven. I can't agree with you more. I felt the same way when I started my journey, looking at why were we so reactive dealing with end stage disease when it was evident in the metabolism, in the hormones, in the way people live life, that they were already suffering. It may not be completely detectable, but it was evident, like diabetes, heart disease, all of these diseases and what I think of as disorders of aging start decades before eruption of significant symptoms, and then they hit a wall, and then we rescue them in conventional medicine instead of proactively turning it around. So to me, aging into the 30s, as hormones began to dip, I did a journal club and I said, why does disease start in the 30s? Why is infertility starting in the 30s? Why do men get heart attacks in the late 30s? Women start losing bone and putting on weight around the middle. And that was a similar, trip for me and journey. So I'd love to hear, as we continue the conversation, what you're excited about in your clinical work and your investigative work with women, particularly optimistic about for 2025.
Well, for my area of interest, I mean, I'm so diverse in terms of all the things I'm interested in, just like you, but I've been doing more of a deep dive into looking at what we've been doing with like our hormone therapies for menopausal women. And like you, like when should we start? I was always taught the same as everybody else that if you're going to do anything with hormones, which once upon a time it was the standard of care, the gold standard to give hormones, and then it became like evil after the Women's Health Initiative, and I never bought into any of that, by the way. I begged my patients to stop thinking about the what they were hearing and just focus on how could hormones go bad for you at any random age that you happen to be going into menopause, which could be many, many different ages. It could be 45, it could be 43, it could be 56, so it doesn't make any sense. But I got about half of my patients to stay on hormones, but the other half, you just ran for the hills. They were so frightened by what was coming out in the media at the time.
This dates back, just to be clear, it dates back to like 2002. I had the exact same reaction. Truth be told, I never liked the type of hormones that were tested. And to your point about research, there was very little research on estrogen from pregnant mares' urine or Provera, so I actually went the European route, and I used micronized progesterone and estrogens that were more derived from natural bioactive substances. But that was a hard sell even back then.
You and I are just clones, I can tell you, Florence, because I also was a very early adapter of the topical transdermal estrogen products. I was trying every single thing out that came on the market. I used bioidentical compounded hormones. I used the micronized progesterone. And so it's always been like just like you. Why should I give something from a horse's urine? That doesn't make any sense if we have something that's compatible and bioidentical with what the human ovary is made of. Why would we use something that's foreign to the body when we have an alternative that is natural for
And
the
we
body?
know the answer to that, right? I mean, I was called on a lot. I actually went to the FDA because I had been used to bringing new peptides and drugs to market, all the way from little children with early puberty, precocious puberty, to women with endometriosis, fibroids, cysts, and and infertility. But we never could win outright because the lobbies and the pharmaceutical companies that own that corner of the universe were pretty powerful. And that also undermined the ability to bring products to the market that would really make a difference in a kind of optimal way, as opposed to undermining. And the risk benefit was clearly different.
Absolutely. So now I'm really more exploring, and we'll see where that goes. I think we should talk about it after I've done more exploration. But in terms of the dosing, because the dosing is important in everything. Like if you eat 1 cup of vegetables a month, it's not the same outcome as 5, 6, 7, 8, 9 cups a day. The same thing, 5 minutes of exercise a month isn't like half hour a day. So even when we have now a world of people who are parading around, I hate to say it that way, but as experts in hormone therapy. And we touched on this a bit. And so now, even in the world of hormone admirers, so to speak, and that there's a whole diverse group of approaches. So I feel like once you get over the hump, which we never even hit the hump, of should hormones even be given, then you get to the nitty gritty. When should you start them? How should you dose them? How should you give them it? Not just give them like progesterone. How should you take it orally? Should you use it as a cream? Should it be a vaginal suppository? Even a rectal treatment?
And some of it's all of the above. And so I agree with you that there's so many unanswered questions, but I think in thoughtful hands with people who have experience both in real patient care and real world research approaches where they can allocate and figure out what's right for each unique individual, it's manageable. There's still a learning curve, but it's manageable. So I agree completely.
I love what you just said, because it's really talking about individualization, that you do this cookie cutter thing that's really becoming the most common way of prescribing hormones, is that everybody gets the same amount because it's easy. If you're doing like a telemedicine company and you just have people you just hire and they're just giving out the same dose and regimen to pretty much everybody, and it's very, very small, very, very small doses, and you're just, it depends on what your goal is. So I think you and I have a different goal than some, because my goal is to optimize health for healthy longevity, which means you have to optimize dose and regimen and so on. If your goal is just to suppress night sweats and hot flashes, which is not a bad goal. I mean, it's really important not to have night sweats and hot flashes. They're not good for any part of a person's body or health. But if that's the only goal...
And not to say they're not fun either.
No, they're terrible. But it turns out it could be a different amount for different, we'll say, outcomes, right? So the amount of estrogen in the form of estradiol that's given to suppress night sweats and hot flashes may not be the same amount to optimize the production of growth factors in the brain or bone health or skin health or genitourinary function and so on. So, the magic is in the dose as well as the regimen. So we really...
And I'd like to add, it's also in the individual woman and her habits, because you could use the same dose in a woman that feels great, but if she changes the way she eats or works out, absorption of estrogen, depending on the route, metabolism of estrogen, excretion of estrogen, and testosterone and progesterone can vary dramatically. So that's what we follow, as I'm sure you do, over the decades.
Absolutely. And I say the same thing. I say the dose I'm giving you now that's working, this may not be the same in a year, because you're not going to be the same person.
Exactly.
So we're, like I said, we're totally aligned, but this is not how everyone is doing it. And we know that.
I know, and they don't understand the evolution, but we can just look practically at what happens to women who don't go on hormones. Most of them don't have hot flashes for life, although I have to say my poor mom into her 80s until I started her on hormones. she had hot flashes, or what I think of now as power surges. And so I think every woman is unique, and the age of presentation and the type of symptoms, as you pointed out, and how they're living life all have weight and a factor into how you want to manage them. Genetics and genetic variants in terms of exactly how your body uses estrogen, why they use it in a certain way, and what your needs are. For some women, if breast cancer is a risk versus osteoporosis, you're going to look at risk benefit for each person. And I'm not afraid of hormones because I don't think they relate to breast cancer over time. I think breast cancer happens in 1 of 7 women, regardless of hormones or not. The data is there for that.
I'm glad that you mentioned breast cancer. I'd like to just say a couple of words, if that's okay, about it.
Sure, yeah, let's do it.
So, estradiol did not evolve in females to give us breast cancer. I think that would be kind of crazy to even think that our own natural hormones, given in proper amounts and so on, is going to give us cancer. But what happens when you have adequate estradiol, it actually works to downregulate the activity of the enzyme aromatase that converts androgens, most of which are coming from the adrenal gland, to predominantly estrone, which is the metabolite that's created, which predominantly acts on one estrogen receptor, which is called the alpha receptor, which in somewhat a little bit simplistic terms, but the alpha receptor, which is on all of the innate immune cells like macrophages, neutrophils, mast cells, we'll say the first attack level of the immune system, it's activating them, and so it's more like pro-inflammatory. So estradiol is amazing. It modulates or regulates the immune system. It turns it on and it turns it off as nature needs it to deal with the challenges that a body faces with pathogens and trauma, injury, and so on. So if you end up in a very properly modulated body with normal levels of inflammation, which should be naturally very low if you're not in the middle of an infection or something, and you have normal levels of estradiol, you're not going to have an upregulation of this enzyme. So inflammation upregulates this enzyme. And then you have...
And just to be clear, the enzyme we're talking about is aromatase, which exists in men and women, usually in the skin and elsewhere in the body. And it can alter androgens to a form of estrogen we don't want, estrone. On estradiol. I actually focus on only using estradiol for all the reasons you said about downregulation. And when we think about breast cancer, the highest incidence is later in life, when in most women, they don't have a lot of estrogen.
Absolutely. Women in menopause are not making any estradiol from their ovaries at all. But if they become in a pro-inflammatory state, and there's a whole array of reasons why people get inflamed throughout their bodies, like they call it inflammaging. They have gut dysbiosis, dysregulation of the immune system, and so on, poor detoxification pathways, and so on, and they get this sort of low level of systemic levels of inflammation. And like you mentioned, the enzyme aromatase is in many organs, and plenty is in adipose tissue, fat tissue. And so when you have a lot of inflammation and it sort of turns on in a higher degree, this enzyme, you convert these androgens from predominantly the adrenal to estrone. And now the breast tissue has a lot of fat, okay? Breasts are composed of glands and ducts and lobular tissues and fat and connective tissue. And you can make a lot of estrone in breast tissue. And if you have inflammation in the breast as well as elsewhere, that's the perfect combination for cancer. You have chronic states of inflammation, then have DNA damage and breakage. You don't have estradiol, and estradiol regulates the function of mitochondria, which controls the cell cycle, which includes when old senescent cells, sometimes called zombie cells, commit programmed cell suicide. They kill themselves. And that's actually under the umbrella control of estradiol that controls a lot of the mitochondria, which controls this. So you now have inflammation causing DNA damage. You have old yucky cells that should die, but they're not dying. They're still living, and they can get misfolded proteins. They can then become cancer cells. Now
they're kind of grow out of control. Just to give the listeners a sense of that, And when you talk about zombie cells, you're talking about cells that can do damage to the system. They're actually dead. What we really want is those killer cells, those killer T cells to protect us, and not senescent, sleepy cells have gone to sleep. They don't do anything, and zombie cells. And just to be clear, so our viewers and listeners can understand, the adrenal glands live over the kidneys on both sides, and they produce a lot of hormones. In fact, in life, they start producing hormones between 3 to 5 years of age, while puberty kicks in a little bit later in life from the ovaries. So they're very active throughout our entire life because they never really turn off. They're very integral to the way we have to function.
That's right. And the adrenal gland makes the most androgens in the body of a female. They make all of these hormones that are called DHEAS. It converts to DHEA. Those are long words, so we don't have to really go into them, but they are in the family of androgens. Like, they're called like male hormones, but they're not in males and females. And the adrenal gland, those hormones can be converted, like we were talking about, to estrogens. And the DHEAS, the ones from the adrenal, will convert first to estrone. And when you have a lot of inflammation, there's an enzyme that can convert estrone to estradiol, and you can convert from estradiol to estrone. But that enzyme is downregulated by inflammation, so you get stuck in estrone, which is more pro-inflammatory and can create growth factors. So now in the breast, you have lack of cell cycle control. You have these zombie cells and senescent cells, which actually create more inflammation. So it's more like, a snowball that just keeps growing with inflammation. You get cancer cells because of the inflammation, DNA damage, senescent cells that don't die and can turn into cancer cells because of misfolded proteins and such. Now you have the breast tissue making estrone in the fat tissue and connective tissue of the breast, and it is what it is. It creates growth factors. But this is not estradiol coming from the ovaries. This is not estradiol coming from hormone therapy. This is produced in that on-site area. And the reason this is happening is because of the aging process and the lack of adequate balanced estradiol and progesterone to control this whole process. So now you get breast cancer, not because of estrogen. It's like in spite of not.
To summarize that, the estradiol is insufficient. Estrone gets manufactured in a perfect storm because you don't turn off the enzyme aromatase that converts natural hormones, these androgen type hormones, in the breast locally where there's a lot of fat that can turn on growth factors and then create damage and growth and tumor growth. So it's really, estradiol is beneficial because it protects our body from going down the wrong path, particularly creating too much estrone. And with inflammation, with fat, we end up with a problem, which is what typically happens.
And it even gets worse from there because breast cancer creates high levels of inflammation in the tissues right around the breast cancer. And the inflammation generated by the breast cancer upregulates that enzyme aromatase in the tissues right surrounding the breast cancer, and then it makes its own estrone supply. Breast cancer makes its own supply of this type of more inflammatory estrogen, which creates more growth factors to grow the breast cancer and to create new blood vessels, because growth is also angiogenesis, creation of new blood vessels. And that's why they give postmenopausal women drugs that block the enzyme aromatase, like anastrozole or arimidex. Those are aromatase inhibitors because it's blocking the breast cancer's creation through inflammation of its own estrogen supply, because you're not blocking.
Just to be clear, you're talking about in breast cancer management. Once the initial cancer is treated or eradicated in many different ways, then going on an anti-aromatase drug like arimidex or anastrozole, which is the generic version of arimidex, actually stops that vicious cycle. So to just take a turn right here and to make sure that we're all on the same page, we're actually saying that estradiol is beneficial because it keeps the body on the right path.
Yes, but so the big takeaway is estradiol that we would give in hormone therapy is different than what is happening in the initiation of breast cancer. And there's such a misunderstanding of using the word estrogen. And it's so important that people understand that estrogen is not a hormone. It's a family of hormones. And within that family, the one that is produced by the ovaries and what we would give in hormone therapy is estradiol. And it has a totally different and balanced effect.
So we're going to come back to menopause, breast cancer, the role of estradiol, why estrone is very different than estradiol, and we could think about that and its connectivity. But for the moment, I'd like to turn to the fact that your book, PCOS SOS, has helped so many women. But there's still many women who are listening to this who don't understand and don't think they can really be helped. They've been frustrated by going maybe from doctor to doctor and no one being able to make sense of their myriad of symptoms because it can be so variable from woman to woman. Can you talk to us a little bit about PCOS and what you mean that about fertility in reproductive age women is synonymous with health, while menstrual irregularity is maybe a sign of poor health?
Absolutely. So PCOS, I call it the poster child of how hormones, reproduction, and metabolic health intersect, because this is really the condition that brings it all together. And it is overwhelming to patients and doctors alike, because like you mentioned, so many organ systems, so many issues can be involved. And the thing that is not well recognized, and it's so important to recognize, is that fundamentally, PCOS is a condition of estradiol insufficiency. And it's always thought of as testosterone excess. And definitely testosterone excess is part of it. But the initiation of this whole problem is because of not having enough estradiol. And that's like just not even understood. So it turns out that when we are little fetuses in our mom's uterus, we are being programmed in terms of how our genes express themselves and how our endocrine system is developing. And that includes things like receptors. So the hormones fit into a receptor, and it's like, it's not really exactly, but like a key into a lock, okay? And it turns out that you need to have those locks, the receptors functioning properly, and these are developing in utero when you're a fetus. If you have exposure to chemicals called endocrine disruptors, and these are prevalent in our world, and the one most researched in PCOS is BPA, bisphenol A, but there are many others. That's the one that has the most research, that it can change how your endocrine system actually develops, and you can have resistance or a malfunction of your estrogen receptors. That's one part, and it's usually involved in people who are genetically susceptible, because we know that 50% of women with PCOS have a first degree relative like sister or mother or daughter who has PCOS as well. So there's a genetic link as well. And then there's other things that come into play like diet and exercise and stress and things that can happen in childhood and so on. So like everything, it's multifactorial and complex. But it turns out that this has been now documented. Women with PCOS do not produce estradiol adequately, and that seems to be something going on in the ovary where the hormones are not working properly, and that enzyme that we've been talking about, aromatase, that in the ovary converts the ovarian produced testosterone into ovarian produced estradiol, that enzyme is not working properly. And it may be related to malfunction of another hormone's receptors, FSH, follicle stimulating hormone, that may not be working properly. It's not creating the proper environment for the aromatase enzyme, and then it doesn't turn off a different hormone called anti-Müllerian hormone. So it's complex. But the bottom line is that the ovaries of women with PCOS, and this is real PCOS, because sometimes other conditions that are similars, but they're really adrenal origin. They're not actually true PCOS. They're androgen excess conditions, but they're not
Like
truly.
hirsutism, for example.
Yeah, but
or
you
too
can
much
have
body hair.
hirsutism. You can have hirsutism and still not have PCOS.
Have
There are other
PCOS.
reasons. But in the true PCOS, the ovaries of those women do not make adequate estradiol. And then on top of that, the hormone receptors for estradiol are not working optimally. So it's like a dual problem. So you end up in a situation where the brain, which has sensors to a lot of different hormones, the brain sensors say not enough estradiol. So the trigger to the ovary to make more estradiol goes first through the pituitary gland, which puts out a hormone called LH, luteinizing hormone, which then travels in the blood to the ovary, which triggers the ovaries to make testosterone, because all estradiol, the estrogen made by the ovaries, is derived from testosterone. 100%. All comes from the testosterone made in the ovaries. So the ovaries start making more testosterone because the brain says, I want more estradiol.
And the route to estradiol is testosterone, which then becomes aromatized using aromatase enzyme in the ovary to estradiol. And having inadequate estradiol and development of these abnormal receptors in utero, whether due to endocrine disruptors or any other interference, most likely with a propensity, a genetic variant in your body that sort of dictates a different path, allows this to go on, and the ovary then is insufficient in the production of estradiol.
And over producing testosterone. And interestingly, the brain doesn't have sensors to testosterone. So the brain will not shut down the production of testosterone. It doesn't respond to that. It doesn't.
So it's still waiting for estradiol to go up.
Yes, but it's not coming enough. So the brain keeps pushing out LH through the pituitary to make more of the testosterone, but then the other pituitary hormone, FSH, follicle stimulating hormone, is not produced adequately and it's not working as well. This is still not totally clear, but so we don't make enough estradiol. So we end up, and it's so simple when you think about it, too much testosterone, like an assembly line, glitch, not enough estradiol. And this gets back to, oh my goodness, what happens if you don't have enough estradiol? Well, estradiol is of metabolic homeostasis. It controls so many things in the body. It's like phenomenal. Estradiol controls all the things related to metabolism. So metabolism is the creation, production, storage, utilization of energy. So it regulates your appetite in all kinds of ways to dictate when you should eat, bringing in energy by eating food. And it dictates how our energy is created, like our mitochondria, so that we burn fat, we create ATP, which is like energy, and glucose regulation. The glucose transport system is regulated by estradiol. So all kinds of things. The gut microbiome is heavily related. So women now, this was proven back in 2015, first in China and then replicated elsewhere in many other studies, that the gut microbial population, all those trillions of different organisms, predominantly bacteria, but viruses and fungi and other things that live in the gut, that they are abnormal. We call it dysbiotic. And then you get impaired gut barrier called leaky gut. And the immune cells have estrogen receptors and they become hyper responsive. A friend of mine back in 1998 at Indiana University Medical School, he discovered that the immune cells in women, the innate immune cells, the first responders of women with PCOS, will respond with a greater amount of inflammatory products, these cytokines, at a lower threshold. So it takes less of the endotoxins coming out from the leaky gut to incite the immune cells that reside around the gut to create this inflammatory cascade and explosion in women with PCOS. So women with PCOS tend to have more systemic inflammation, which then triggers more insulin resistance. So then you're more prone to diabetes, because women with PCOS have like 7 times higher incidence at age 40 of diabetes compared to other women. So the first step
They
in
also
solving,
have lipid disorders, skin
oh my
disorders,
goodness, they have
infertility. So there's a whole cascade that occurs as a vicious cycle, but really starts in utero and begins to worsen over life because of the messages and the miscommunication between the brain sensors of your hormones and what's circulating and the overproduction of testosterone and LH and the underproduction of estradiol and FSH. And then inflammation kicks in to boot because of the metabolic need for estradiol throughout the body, and it's not getting sufficient signals because estradiol is too low. Does that
And
capture it?
and when you look at the metabolic, this is why the connection between perimenopause, menopause, and PCOS. So more like you could say perimenopause, because there's still estrogen, obviously, in perimenopause, and there's estrogen in the form of estradiol in PCOS women, but it becomes insufficient. It's not optimal during those times. So if you look at the metabolic issues that are developing in women in PCOS and in perimenopause, they're identical. Like you said, high cholesterol. That's like almost universal in women as they enter into menopause because estradiol controls so much relating to cholesterol and so forth, and the receptors for cholesterol in the liver to pull it back out for disposal and so on, all regulated by estradiol. So we have this, complex issues with all the metabolic health, and metabolism and fertility are intimately connected. That's why now, finally, I knew this when I was doing all those thousands of deliveries, pregnancy is the ultimate stress test for women during the reproductive years. And if you fail it by getting pregnancy-related hypertension, preeclampsia, gestational diabetes, preterm labor, if you have like a growth-restricted baby, a macrosoma, too big of a baby, all of those are warning signs, not just for when you're pregnant, of course they are, but for later in life, when you transition into menopause, when your estradiol levels will drop, that you will have a higher risk of developing all of these metabolic complications like hypertension and heart disease and strokes and lipid problems and all of those things, along with all the other things like osteoarthritis, osteoporosis, and even dementias, because all of these are interconnected. And so now we are recognizing, and everyone who sees an internist or a family doctor, endocrinologist, when they're older going into menopause, they should be taking your history about what happened when you were pregnant. If you
Absolutely.
had PCOS, infertility, irregular cycles, the menstrual cycle, as you mentioned earlier, is now recognized as a real issue. It's a vital sign of the health of a woman during the reproductive years,
It
just like blood
telescopes your
pressure.
future health destiny and your trajectory
Absolutely.
of health so that decades before you're actually going to end up with a disorder of aging at an earlier age than the average woman. You're already expressing those symptoms 'cause during pregnancy, the stress on the system allows it to emerge. And therefore, ultimately, that should be taken seriously by any physician who's seeing a woman and taking her history during the perimenopause, asking about family history, asking about her pregnancy, asking about her own history is going to be of vital importance and really should dictate how we can proactively optimize health from the very get-go, even in young children. I see many children with metabolic syndrome who have a similar kind of process going on. And if you can stop that process early in life, you're giving them a gift of health and optimal health for life. So we're in complete agreement there. I don't know if we have time, if you can keep it maybe short and direct, what your process might be with a new patient who presents with PCOS-like symptoms, and what do you typically recommend to help these women?
I do lots of testing in terms of measuring blood tests, looking at inflammation markers. Thyroid, Hashimoto's much more common in women with PCOS, so I test for that. I test nutrient status because they have gut problems, so they could have absorption issues. Of course, all their hormones that relate to the adrenal, to androgens, to estrogens, and progesterone, and
Are
so
you
on. So I get
testing
all the labs.
anti-Müllerian factor or
I
in
do.
women of a certain age?
Right. So anti-Müllerian hormone is not something useful in teenagers. But once you get into the 20s and thereafter, yes, anti-Müllerian, not in menopause though, but yes, and the
Well,
reproductive
it's
years.
predictive, but I don't find it that predictive. Like I have had a lot of women who have low levels and are still able to get pregnant
Yeah.
spontaneously.
Well, PCOS typically they'll have very high levels of anti-Müllerian hormone, not because they have amazing fertility. No, it's because that's part of this regulation in the ovary that they can't shut down the production the way they should.
Dysregulation in the
So that's a
ovary.
whole complicated
Different
topic.
topic,
But
another
that's part of
podcast.
the diagnosis, right?
Right.
It can be part of the diagnosis. And so once I make the diagnosis with an ultrasound of the ovaries as well, because that's part of also the diagnosis, and irregular cycles. So, of course, I take a menstrual history. Then what do I do? Actually, a lot of it is the same as I do for perimenopause. It's all the lifestyle issues. And don't underestimate the power of lifestyle medicine. When you work to establish a healthy gut through diet and nutrition supplements that are appropriate, and you also work on sleep hygiene and getting proper sleep regimen, and testing for sleep apnea and sleep disordered breathing, which is very frequently abnormal in women with PCOS and going into menopause as well. And then you want to get fitness optimized, get on an exercise program. We in my office actually do body composition, so not just BMI. So you want to know how much fat, how much muscle. We do fitness assessments, exercise prescriptions, because we bought in wholeheartedly to fitness is a vital sign, exercise is medicine. So we always work with that.
I used to have prescription pads when I started Women's Health in the
Yes,
90s that had exercise on it and then also food. And
with it.
I used to say if exercise was a pill, everybody should be on it, right?
Well, why am I totally not
What do you
surprised?
do pharmaceutically or with hormones? Is there
Well,
a first step solution that you try in most women?
yes. Well, depending on what their situation is, like you mentioned early on, that there's a big spectrum of how people are in terms of severity and presentations. But if they have a lot of acne, cystic acne, and hirsutism, I will use spironolactone. That is a very interesting drug that actually can help to block androgens, but it
The
also
end organs on the
at
skin.
the end organs, right? So it blocks it, and so can really help. But it actually has other effects. It's actually a mild diuretic, potassium sparing diuretic. It's kind of anti-inflammatory. It's like an anti-aldosterone, which is a hormone from the adrenal. So it actually has some interesting sort of anti-inflammatory benefits too. But there are other restrictions. You can't take it if you're trying to get pregnant. It can be a teratogen. It can, if you have a boy baby, you're in trouble because it blocks the androgen effects, into to a significant degree. But it can be very, very helpful in terms of acne, especially. And so I include that. I actually I give women in perimenopause hormone supplementation. This is not common. I don't know anyone that's doing this, but it's better than birth control pills, in
I
my
do the same
opinion.
thing.
My gosh, it's so amazing, because if you have an insufficiency of a hormone, whether it's thyroid or estradiol or progesterone, I do the simple thinking thing. I give the hormone that you're deficient or insufficient in. Like, why would I give an alternative?
Gets you
Just like I'm
back
not
in balance.
exactly. And it's one of those catch-22s. You can't heal without the hormones, but until you're healed, you won't make the hormones. So that, the menopause, you'll never make them again. But that's not true for PCOS. You can actually help to restore, it seems to me, I don't have proof of this, but to help restore receptor functionality and to deal with the gut microbiome much better when you have all of
What's
these.
your usual hormone, let's say, approach initially, let's say in a 30-year young woman who you've made the definitive diagnosis of PCOS? She has a lot of the sequelae of it in terms of her symptomatology, lipids and sugar mismanagement or disorder of what I think of as carbohydrate metabolism. What would be your first line approach hormonally?
Well, from not the lifestyle, just from the hormones, I will
Yes.
often start
We
with,
agree on lifestyle. I think
yeah, everybody's
anything you
going to
could
agree
do
on
when you're
that.
right.
So, there's some variation, but if I start with an estradiol patch, I will use anywhere from, depending on their situation, like how often they have periods, and I do measure these hormones first, 0.05, 0.075, or zero point 0.1 patch. So I will give a patch, and then I do progesterone. If they're not having periods at all, then I just give it somewhat arbitrarily for the first 14 days of each month, because it's easy to remember, start day one. Progesterone has many, many benefits. It's also an anti-androgen, so it down-regulates the receptor for testosterone. So it's very good in that respect. And we also need to lower the risk of endometrial adenocarcinoma, which is elevated in women with PCOS. So we have to clean out that uterine lining. You got to get an induced period on a very regular basis.
And what's really interesting and has always confused me a little bit is Without adequate estradiol, because it's very common to give progesterone for PCOS, but without adequate estradiol, you're getting this lining that's irregular because your menstrual cycle may be irregular, and you have to organize it with progesterone to be able to shed it. So when you have irregular periods, progesterone definitely plays a role, but your use of the patch is interesting. That's not very common.
No, I think I invented that. But, maybe other people did simultaneously. But if it's logical, to give a fake estrogen for the body, ethinyl estradiol, why would you not give the much safer version, which is the human bioidentical estradiol?
Do you give it as a patch mainly or cream, or do you ever give it as a pill? This is a trick question. What's your feeling about using estradiol orally in women as they age perimenopausally into menopause? And just like in PCOS.
2 thumbs down, because estradiol goes through the first pass, it goes through the digestive tract into the liver, where it is mostly converted through the amazing properties of the liver, which does all these, like we'll say, detoxification. So you have methylation, sulfation, conjugation, glucuronidation. It changes things, okay? So it changes the estradiol predominantly into estrone, and we've talked about estrone. It's good, but not when you have too much of it, and that's not the way the nature intended it.
Most of the time when we produce estradiol, we're producing it directly out of our ovaries. So the reason not to take oral, this is a little bit of a conundrum to me. Oral estradiol is for all the reasons you're articulating. It has the first pass through the liver and produces estrone and causes all sorts of problems. And a lot of people relate it to lipids. However, one of the things I've seen as a trend almost universally is women who present in perimenopause and menopause who've been told their lipids are amazing. And that usually means they have very high HDL or good cholesterol. As they enter perimenopause and menopause, the LDL, if they're at risk for cholesterol or high levels of cholesterol, starts skyrocketing. So there are doctors who believe that using oral estradiol corrects that, because women who have their own estradiol, menopausally, reproductive age, usually have lower LDL and lower ApoB. Is your feeling that is maybe a risk benefit, but not worth the risk because you're worrying about the first pass through the liver and the alteration to estrone when you take oral estradiol?
If you are incredibly healthy and you do not have any systemic inflammation, which is not typical, okay? Not typical, then you can convert estrone back into estradiol in the body. But I don't assume that's going to happen readily, because most people are not so great in their health department when they're perimenopause and menopausal in the early stages or even or later, and they have more levels of inflammation, which will make it less probable that you're going to convert because of the enzyme that becomes dysregulated that converts estrone back into estradiol. So you're going to get stuck with too much estrone, and that is not going to be ultimately beneficial. Now, there are different estrogen receptors in different organs, different propensities for different receptor types, and they're all important, but they work in a beautiful synergy. The receptors actually interact with one another. So we're not smarter than nature. Never think that, okay? So I'm just saying the simple thing. Nature gives us estradiol. Estradiol has the balanced effect on all the receptors. I want to give estradiol. If I give oral estradiol, it's not going into the blood as estradiol. It's going in as estrone. And I would much prefer to give nature the ability to handle it itself and use estradiol the way it wants.
Your original body physiology. So
Very,
I've been
very
with you.
basic.
I've been doing that for over 25 years. Exactly that. I only use estradiol for that reason, and I have never given it orally, with very rare exceptions in perimenopausal women who have very severe menstrual pain and discomfort, and using the pill really makes a difference in terms of transitioning. And once they transition, if they're pretty healthy otherwise with no smoking and other things, I watch them carefully, I can count those number of women. In general, it's creams or patches for estradiol. So I think we're in agreement there. And I don't know if you want to point out anything else in terms of menopause, because we are running out of time and there's so much to talk about. I'm sure women are going to love this podcast. Is there anything you want to add that we might have missed, and because we got carried away in numbers of
Well, I think just sort of a unifying theme is that lifestyle is essential for optimization of health. But no matter how much you exercise, no matter how much you eat your vegetables, you're not going to replace your vital life hormones, your estradiol, your progesterone. They're not going to be there. The same as if you had low thyroid. No one, if they had their thyroid removed because of any reason, is going to be told just to exercise, do meditation, and eat your veggies. So why should we say that to women, whether they have insufficiencies because they have PCOS, whether they have insufficiencies because they're transitioning into perimenopause and menopause? Why would we say just do something
Just
else?
live
There
well.
is
I
no
agree. And I think
substitute.
it's because it feels like the lesser of two evils, but you're really harming women if you don't understand this interaction between receptors, hormones, enzymes that change one hormone to the other hormone and what it can do with inflammation. So I am completely in your corner. I think
So
it's brilliant.
one last thing. Every cell in your body is a different age. Very few cells are the same ones that you were born with. There's some, like maybe some neurons, heart muscle cells, but most of the cells in your body were born much later from your stem cell pool. They are born genetically programmed to do whatever they're genetically programmed to do. They don't know how old you are. If you give them what they need to optimally function, and that includes the micronutrients, the macronutrients, avoidance of toxicants and toxins that would be like biological or chemical. And you give them the proper hormones, which are the instruction manual. The hormones tell the cells what to do with all these other ingredients. Then you can optimize cellular function within each organ, no matter where you are in life, because the cells will do what they're designed to do. It's so simple. And hormones are not optional for optimizing health at any age. And we need to just move on from that crazy debate that hormones are bad. Hormones are essential and
They're
they're
a
necessary.
natural life force. They're physiologically.
Absolutely.
You said it beautifully, Felice. That's a wonderful note to kind of summarize some of the topics that we barely touched on and others that we dug into. There's so much more to understand for women, and I hope we can spread the word in that way. I hope you'll share this with your constituents and listeners, and we certainly will too, because as always, I always learn a lot because you dig deep into the science. So I'm impressed. That's fantastic. An inquisitive mind, and I think we're both open-minded skeptics, because I also did integrative medicine. Not only do we do in-body and body comp because we know BMIs are worthless, all you get. And I do VO2s. We have an exercise physiologist here. We have a truly integrative kind of approach to the way we evaluate individuals. Yeah. So I guess the last couple of questions would be, what is your message? Is there one message you'd like to leave women who are struggling either with PCOS or other dysregularities, perimenopause or menopause? What would you advise them as a first step besides exercise, eating right, getting 6 to 8 hours minimum of sleep, and avoiding inflammation?
Well, that is absolutely true. But I would just add to that, that I love estradiol and I also love progesterone, is that you should love yourself. You need to be optimistic. You need to have purpose and friends and love and work on the things that really matter to you. Definitely focus on your health, but don't become obsessed with everything about your health and neglect the people you love and the things you enjoy and creating purpose in life, because that will also give you health. So,
Yes,
do
optimism, compassion, gratitude. Start every day with gratitude. I've learned that myself, and I couldn't agree more. In fact, you answered the final question I usually ask guests, but you can feel free if you have something else to add, is if anyone ever stopped you on the street and it could pertain to your GYN and OBGYN hat, your integrative hat, and you're chatting with someone at a party or on a plane, and they ask you, doctor, what is the most important thing I can do to optimize my health? Is there one thing you can point to? Because you already said it, the love, the self-love, the love around your community, relationships, and supporting the people in your life. But is there anything you want to add? I mean, you've said it all, Felice. So.
Well, I would say that kind of what you said. And this is my dad said. And he lived to 98. He said to me, every day is a good day because I woke up. So, so you know what? Just celebrate that you were here, that you were born. Like think of the miracle that you were created from an egg and a sperm. And just say, I am the luckiest person every day because I am here and I have a life and I have a purpose and I can make every day count.
So beautiful. Everyone feels that. And there are actually studies that show when you go beyond that and you start with yourself, but you go beyond that, even if you've had a heart attack or a stroke, you go home to someone who loves you, and better yet, unconditional love from a dog or a cat, you live longer. And they have studies in women with breast cancer and others that metastatic disease, if you meet in a social gathering and you share your concerns, women can live longer in those settings where they share their worries and their fears. And that's work that was published at Columbia and Stanford, and I find it fascinating. So on that note, I think we'll call an end to this podcast, although I think we could go on for hours.
It's been a pleasure.
Same here. Okay. What is the best way, Felice, for our listeners to find you, to follow you, to hear your wisdom and share your thoughts with them? I'm sure many of them are going to be interested in doing so.
So it's like you mentioned, the Integrative Medical Group of Irvine here in Southern California in Orange County. I see patients all the time. So of course people can be a patient. In addition, I have an Instagram live that I do most every week and a YouTube channel which has a lot of information for people that might enjoy.